Bismillahirrahmanirrahim. Okay, this is about the pathology of liver. It's a very important chapter. Inshallah, after the session, this is our expectation. After this session, you can able to list the various types of jaundice and explain their associated clinical syndromes and explain the pathogenesis of liver failure and the clinical outcome. And you can able to differentiate between the alcoholic and non-alcoholic steatohepatitis and viral hepatitis, drug-induced or toxin-induced liver damage with reference to morphological and clinicopathological features to arrive at appropriate diagnosis. And you also can able to differentiate between the primary and metastatic carcinoma in liver. It's very important. And with reference to morphological and clinical pathological features, again to come to a diagnosis. So before going to the pathology of liver as such, let us discuss about microanatomy of liver, very important. And liver, when you see microscopically, it will be of lobules. It will be of lobules and they are polyhedral shape. Okay, they are polyhedral shape and it's like a hexagons. Okay, 8-sided shape. And if you see the lobules in the outer side, in the periphery, they have 3 structures together. It is called portal triad. It is called portal triad. So they have in the portal triad bile duct, hepatic artery and portal vein. In the center you will have a central vein. In the center you will have a central vein. So from the portal tract, portal triad, then the portal vein goes to the central vein and bile canaliculae will come and they come to the duct. Bile canaliculae will come to the duct and hepatic artery goes along with the portal vein. Okay, so this is how the vascular architecture and bile canaliculae and the bile intrahepatic bile duct architecture. Now the hepatocytes are arranged in between, okay, as a plates, single layer of cells, okay, which means that one cell layer thickness. It is very important. If it becomes tumorous, if it becomes nodules, they will have more number of cells in the plate. If it is a single cell layer, it is normal arrangement. And in the hepatocynocytes, it is lined by the endothelial cells and they also have Kupffer cells and the satellite cells. These cells are very important. They play a role in pathogenesis of cirrhosis. Now coming to the lobular structure of the hepatic lobules. Actually we divide the lobules into different zones. So there are 2 models in the approach towards the classification of the liver lobules. One is called lobular model. Other one is Acinar model. Let me explain first the lobular model, then I will explain the Acinar model. Very, very important, related to the histopathology, because when you take a biopsy, our approach is towards this model. Okay, so and you all know that the lobule in the periphery, they have portal triad, right? So you all know that hepatic artery comes like this and the portal vein comes like this and they go inside the lobule like this, right? So the hepatic artery follows the portal vein and they all go to the central vein. And the bile duct, in between the hepatocytes there is a bile canaliculae. All the canaliculae joins and forms the duct and it comes out, right? Now blood supply comes from the periphery, goes to the central vein. It comes from the periphery and goes to the central vein. So the area surrounding the portal triad, the area surrounding the portal triad will get very good oxygen, So that is called periportal area. The area surrounding the central vein is called centrilobular area. It is called centrilobular area. The centrilobular area will receive less oxygen, because the oxygen rich blood enters the portal triad and portal area, and the surrounding tissue will take the oxygens. So the oxygen level will be reduced when they go to the central vein. So this is what happens in the lobules. So we have a periportal area and the centrilobular area. Now if there is ischemia, which area will be affected? Centrilobular area will be affected, okay, because they normally receive less oxygen. Okay. Now if you see the Acinar model, we divide the each triangular structure of the lobule into three zones. Zone 1, zone 2, zone 3. Zone 1 is the area which receive very good oxygen. Zone 3 is the area which receive less oxygen. Zone 3 is nothing but centrilobular area. Zone 1 is nothing but periportal area. So zone 1 corresponds to periportal area, zone 3 corresponds to centrilobular area. It's very, very important. So please understand, if there is ischemia, I will be seeing changes in the centrilobular area. And I am going to discuss a little bit about the hepatocytes located in the centrilobular area. The hepatocytes, the liver cells located in the centrilobular area, they are rich in enzymes. And mitochondria. So any drugs or any toxins comes through the blood. So if they go to the centrilobular area, the hepatocytes takes it very actively, and they detoxify it. So any toxic injury which reflects in the centrilobular area. So if I see any changes in the centrilobular area, I will be thinking of two conditions: whether it is ischemic damage or it is toxic damage. Okay, now if there is inflammation in the periportal area, okay, for example, if the infection is coming in the blood, some virus is coming in the blood, which cell they saw first, they will go into that cell. Okay, so periportal area is affected in the infections. So if there is inflammation, if I see in the periportal area, so I will be thinking of some infectious conditions. So this is very important for you to know the different zones and the lobular architecture of the liver. Okay, so this is what I explained here. The zone 1 is most highly oxygenated zone, and which is around the portal tract. Zone 3, which surrounds the central vein, is oxygen poor. Ischemic injury usually affects the zone 3 before the other zones. Now coming to the intermediate or mid-lobular zone is zone 2. The differences in hepatocytes are not restricted to blood flow. The acini is also heterogeneous, which means the hepatocytes nature is also different. I will be keep on repeating. Understand? Please don't interfere when I am discussing. So now what we discussed so far is about the oxygen rich area, oxygen poor area. Okay, now I am going to discuss about the nature of the hepatocytes. Hepatocytes look in the zone 3 and the zone 1 are different. That's what we are telling. It is heterogeneous. They are not homogeneous. Homogeneous means the hepatocytes in the zone 3 and zone 1 are same. They are heterogeneous in nature, which means that the hepatocytes has some function here, and in the zone 1 they have some function here. So in the zone 3, the hepatocyte function is more towards detoxification, That is because they have lot of enzymes. So they involve in detoxification and biotransformation of any chemicals, and in particular any toxic injury, so that's why it reflects in the zone 3. So if you see any injury in the zone 3, you should think of ischemia or toxicity. Now coming to the laboratory investigations which you do in the liver diseases. So now there are 3 types of functions we see through the laboratory investigations. One is hepatocyte damage, the integrity of the hepatocyte, then biliary function, then hepatocyte function. So to see the injury of to know the injury of the hepatocytes, we measure certain enzymes, especially these 2 enzymes, serum aspartate aminotransferase, serum alanine aminotransferase. If there is hepatocyte injury, these 2 enzymes will be elevated. And if there is increase in serum bilirubin, there is some problem in the bile excretion. And if it is unconjugated bilirubin is increased, there is some problem in the prehepatic or hepatic cause. And if it is conjugated is only increasing, it is problem in the post-hepatic area. So now, if the bile canaliculi is affected, then the enzymes serum alkaline phosphatase, gamma glutamyl transpeptidase is increased. These 2 will be increased. And to know the hepatocyte function, we look for serum albumin. If the hepatocyte function is affected, serum albumin will be reduced. Okay, albumin level will be reduced, and the prothrombin time will be increased. And serum ammonia level will be increased. Okay, if the hepatocyte function is disturbed, hepatocyte function is impaired or disturbed, you will be seeing serum albumin level will be decreased, because liver is the one synthesize the albumin, and prothrombin time will be increased because liver produces clotting factors 5, 7, 10, prothrombin and fibrinogen. So these clotting factors will be reduced, that will lead to bleeding. So that's why the prothrombin time is increased. It is very important, because if the prothrombin time is increased, the patient usually bleed from mouth and anus and they die. Okay, so it is very important complication of liver failure. Then serum ammonia will be increased, it will affect the brain. So these are the things we look in the laboratory evaluation, and to know the disease which area is affected. So the most common diseases are viral hepatitis, alcoholic liver disease, non-alcoholic fatty liver disease, and hepatocellular carcinoma. These are the most commonest disease which a person can encounter. And nowadays the toxic and drug-induced liver damage is becoming very common. So let us discuss about different types of hepatic failure. So now we divide them into acute liver failure and the chronic liver failure. Acute liver failure, if they produce massive hepatic necrosis, it is highly dangerous. And it is most commonly due to drugs and viral hepatitis. And they produce hepatic insufficiency. Hepatic function is affected, and within 2 to 3 weeks they develop a brain disorder that is called hepatic encephalopathy. Their ammonia level will be increased very high, and it will spoil the brain, and they will go for coma. So it is called hepatic encephalopathy, and within 2 to 3 weeks it happens. It actually due to massive hepatic necrosis. Large area of the liver goes for necrosis. and the patient need immediately liver transplantation. Okay, so they have to be replaced. The liver has to be replaced. Now coming to the chronic liver disease, which is the most commonest root of hepatic failure. This is the most commonest root of hepatic failure. It is otherwise called as end-stage chronic liver disease. What happens is they produce cirrhosis. They produce cirrhosis, usually seen in chronic viral infections. Okay, hepatitis B, hepatitis C, alcohol. Okay, so these are the most commonest cause for chronic liver damage. Most commonest cause for chronic liver damage. They produce cirrhosis. They produce cirrhosis. The complete liver will go for fibrosis. The complete liver will go for fibrosis. Now coming to the hepatic dysfunction without necrosis. Hepatic dysfunction without necrosis. See, there is dysfunction but there is no necrosis. It is commonly due to drugs or toxin related injury. Okay, and it can be seen in the pregnancy, or there is a syndrome called Ray syndrome. This is due to mitochondrial injury. Okay, it is commonly seen in even in paracetamol. Okay, if you give a paracetamol, okay, Calpol, so what happens is the commonest used analgesic. So that will damage the mitochondria of the liver. Then they will go for liver failure. They will go for liver dysfunction. But yani, this is reversible. This is reversible. So this is the reversible dysfunction. If there is necrosis, then it will not be reversible. Then it will not be reversible. So this is the most important three types of liver failure. One is acute liver failure with massive necrosis, hepatic dysfunction without necrosis, other one is chronic liver failure. So what will happen if liver fails? You know, you will get a jaundice, okay, because bilirubin excretion is affected, and the liver cannot produce albumin. That will produce hypoalbuminemia, and that leads to peripheral edema. His whole body will be swelling, and they also produce hyperammonemia, which means the ammonia level will be increased. That will affect the cerebrum. That will lead to cerebral dysfunction. The patient will go for coma. That is called hepatic encephalopathy. And the body will have a characteristic smell, musty or sweet or sour smell. It is called fetor hepaticus. The characteristic body odor is seen in the liver failure patient. And they have impaired estrogen metabolism. That will increase the estrogen level. And that leads to palmar erythema due to local vasodilation. What happens in hyperestrogenemia? All the peripheral vessels vasodilate, and the patient, especially in the palms, it will be very reddish palm they have. So it is called palmar erythema. And they produce angioma, blood vessel tumors. Collection of blood vessels will be seen. Okay, and they also have, if it is a male, they have gynecomastia and hypogonadism because of hyperestrogen. The male will develop female-like breast. That is called gynecomastia, and they also produce hypogonadism. The testis will go for atrophy. And they also produce clotting factors. Liver also normally produce clotting factors that will be affected. Impaired hepatic synthesis of clotting factor, which leads to coagulopathy. Coagulopathy means bleeding disorder, which leads to coagulopathy. So these are the things happens if the liver fails. Okay, the patient go for coma because of increased ammonia level, and the patient go for bleeding because their clotting factor will be reduced. And other effects are due to increased estrogen. Now coming to the three syndromes happens when there is liver failure. One is hepatic encephalopathy, hepatorenal syndrome, and hepatopulmonary syndrome. Hepatic encephalopathy, as I told earlier, it is due to increased ammonia level that will damage the astrocytes. These are the supporting cells in the brain. Okay, so what happens is the neurotransmission is affected, that will lead to confusion, deterioration, and they lead to coma. Slowly they develop coma, and they produce characteristic tremor that is called astrixis. Astrixis. Okay. So at least you should know that there is an increased level of ammonia which happens in the liver failure, that will affect the CNS neurotransmission and astrocyte, and that leads to hepatic coma. That leads to a coma that is called hepatic coma. This whole situation is called hepatic encephalopathy. The whole situation is called hepatic encephalopathy. Now coming to the hepatorenal syndrome. And in the hepatorenal syndrome, I told in hepatic failure there is increased estrogen, right? This increased estrogen will cause peripheral vasodilation. It causes vasodilation in the periphery. So the blood going to the kidney is reduced. The blood going to the kidney is reduced. That will lead to decreased GFR. That leads to decreased GFR. So when the blood going to the kidney is less, the waste product cannot be excreted. The waste product cannot be excreted. So there will be increase in serum creatinine. Okay, there will be increased in serum creatinine. It is very, very important. So it is a sign of renal failure. It is a sign of renal failure. Here the kidney is failing because of liver. Because of liver it is, but otherwise the kidney is normal. Otherwise the kidney is normal, and that's why we call it is a hepatorenal syndrome. If the person is having increased serum creatinine, normally to know what is happening in the kidney, we take a renal biopsy. We take a renal biopsy. In this state, the renal biopsy will be normal. Renal biopsy will be normal, and if you take a liver biopsy, the patient will have fibrosis, cirrhosis. The patient will have cirrhosis that leads to liver failure. Liver failure leading to renal failure. Liver failure leading to renal failure. That is called hepatorenal syndrome. Now coming to the hepatopulmonary syndrome, because of liver failure, respiration is affected. Respiration is affected because of intrapulmonary vasodilation due to increased nitric oxide. Due to increased nitric oxide, that produce more pulmonary pressure, so the patient cannot breathe. So this is all the three syndromes which you should know very well. Understand? So the most important thing is all these three happening because of failure in the liver failure, because of liver failure. And once again I am summarizing it. It's very, very important. One is hepatic encephalopathy, which happens due to increased ammonia, in the liver failure. And hepatorenal syndrome happens due to peripheral vasodilation, which reduces the GFR. Actually it causes arteriolar vasoconstriction in the kidney, that reduces the GFR, that increases the serum creatinine. So it looks like a renal failure, but actually this renal failure is happening due to reduced GFR, not to the problem in the kidney, and it is actually happening due to liver failure. And in the pulmonary syndrome, hepatopulmonary syndrome, the difficulty in breathing comes because of pulmonary vasodilation, due to increased nitric oxide. Now coming to the bilirubin metabolism, actually they already discussed by Dr. Rukshana, so I will give a small, it will be like a revision for you. So how the bilirubin is formed? First you should know that it comes from the old RBCs. Okay, the old RBCs is taken by the macrophage, and the macrophage produces biliverdin, and it comes out, and the bilirubin and albumin complex will be formed in the blood, and the bilirubin albumin complex will go into the liver, and liver cells takes it, and they do conjugation by the enzyme glucuronide transferase. Okay, so this enzyme will conjugate it. Why they conjugate it? Make them into dissolvable. Okay, so then the conjugated bilirubin comes out to the canaliculae, and from canaliculae it goes to the duct, intrahepatic duct, then it comes out of the extrahepatic duct, and it comes to the duodenum. Then it goes to the large intestine, colon, and it is converted into urobilinogen. It is converted into urobilinogen by the intestinal bacteria. Then it is excreted in the feces. It is excreted in the feces. Now some of the urobilinogen is absorbed, and it goes to the blood, and it is excreted in the urine. It is excreted in the urine. So this is the normal bilirubin metabolism. This is the normal bilirubin metabolism. Okay, now if any problem happens in the destruction of RBC, more destruction, you get more bilirubin. You get more bilirubin. It is called prehepatic cause. It is called prehepatic cause. If there is any problem in the liver cell, okay, where they cannot do conjugation due to some enzyme deficiency, hereditary enzyme deficiency, or the liver cell is damaged by the virus, okay, or the liver cell is damaged by the toxin, or the liver cell is damaged by the alcoholism. So these are all the things. The liver cell is damaged where they cannot conjugate the bilirubin. So unconjugated bilirubin will be increased. Unconjugated bilirubin will be increased. It will be supported by the increased AST ALT. Increased AST ALT, the enzymes which comes when there is liver cell damage. When there is liver cell damage. Okay, now if there is problem here in the bile duct, it is having some tumor, it is having some stone, or there is fibrosis, it produces obstruction. It produces obstruction. In this case, conjugated bilirubin will be increased. Conjugated bilirubin will be increased. So these are the different reasons for bilirubinemia, increased bilirubin. That is called jaundice. If it deposit in the skin, deposit in the mucus, if it deposit in the sclera, it is called jaundice. Okay, so hyperbilirubinemia denotes increased blood level of bilirubin, okay, which means there is no deposition. There is no deposition. If there is deposition, it is called jaundice. It is called jaundice. So it usually deposits in the skin and the sclera. Okay, so this is the sclera. Okay, so you can see the yellow color pigmentation. So this is called jaundice. Usually it comes if there is bilirubin level is more than 2.5 to 3 milligram per deciliter. Cholestasis means if there is obstruction in the bile duct, intrahepatic or extrahepatic, the bile canaliculae, the bile is stored. The bile canaliculae, the bile is stored, stayed for longer period. That is called cholestasis. Stasis means staying. Chole means the bile staying in the canaliculae. The bile staying in the canaliculae, and you can see bile pigment in the hepatocytes. You can see bile pigment in the hepatocytes. So if the jaundice comes due to the obstruction, it is called cholestatic jaundice. Cholestatic jaundice. Now sometimes in the neonates, newborn, the bilirubin level will be more. So we do phototherapy. We give phototherapy to oxidize the bilirubin to excrete it in the urine. To excrete it in the urine. What happens is, if the too much of bilirubin in the neonate, that bilirubin can go to the brain, it can give permanent damage. It can cause permanent damage. It is called kernicterus. It is called kernicterus. So these are the problems we see in the impaired bilirubin metabolism. If the bilirubin metabolism is affected, these are the things we can see. Now coming to the jaundice. So jaundice, as I said in the earlier slide, if there is more destruction, you see the jaundice. If there is problem in the hepatocyte conjugation, you see the jaundice. If there is obstruction, you will be seeing the jaundice. Okay. Now in obstruction, the jaundice is little bit different. Okay, it will produce cholestasis. It will produce cholestasis. So this actually in the biochemistry they discuss more. So I am discussing the cholestasis, very important. See, now this is the common hepatic duct, and this duct, cystic duct, comes from the gallbladder, and they all form the common bile duct, and it goes to the second part of the duodenum. It goes to the second part of the duodenum. Now if any obstruction happening in this path, any obstruction happening in this path, this is outside the liver. This is outside the liver. That is called extrahepatic biliary ducts. Extrahepatic biliary ducts. If it is inside the liver, it is called intrahepatic biliary duct. Actually, this will be my last recording. Actually, hereafter I will not record anything. Okay, I will tell the reason in the end of the class. So now this is called extrahepatic biliary duct, and anything duct inside the liver, it is called intrahepatic biliary duct. Usually intrahepatic biliary duct, the problem is seen in the children. The problem is seen in the children. Extrahepatic biliary duct usually seen in the adult. The problem in the extrahepatic biliary duct is seen in the adult. Usually it will be of tumors, or it will be of fibrosis, or stone obstruction, These are the most commonest cause for extrahepatic biliary obstruction. So what happens is the bile will not reach the duodenum. The bile will not reach the duodenum, and the bile stasis will be retrograde. It will be retrograde, and in the bile canaliculae you see the bile. In the bile canaliculae you will be seeing the bile like this. These are the bile canaliculae filled with the bile. Okay, so it is called bile stasis. It is called bile stasis. Now, if it is becoming there for longer period, it will create necrosis. It is called biliary necrosis. And if it is there for very longer period, it will create cirrhosis. It will create fibrosis. It is called bile fibrosis, otherwise called as bile cirrhosis. In the cirrhotic area, you will be seeing the bile pigment. In the cirrhotic area, you will be seeing the bile pigment. So it gives us a clue. It is happening due to cholestasis. It is happening due to cholestasis. Now, the clinical feature in obstructive jaundice is the patient will have pale stool. Pale stool. The feces will be pale in appearance, pale in color, because the urobilinogen is less. Urobilinogen is less, because the bile coming to the duodenum is very less because of obstruction. And one more thing you should understand, if it is accompanied by the pancreatitis, then lipase level will be less. And the fat digestion will not happen. The stool will have fatty stool. The stool will be fatty stool, and the patient will tell, my feces is very greasy and I cannot wash it. Okay, it is not going. So this is the complaint. It is a characteristic feature of steatohepatitis. It is called steatohepatitis. Sometimes the fat will literally come out. It is called steatohepatitis, and the patient will have pale stool. That is the clinical feature of obstructive jaundice. Now coming to the cirrhosis. And cirrhosis, it is a diffuse process, okay, which means all the liver is affected, all areas of the liver is affected, and it is characterized by the fibrosis, and it has abnormal nodules. Now, if the nodule is less than 3 millimeter, and it is called micronodules. If the nodule is more than 1 centimeter, it is called macronodules. And macronodules or micronodules, these nodules are regenerating liver cells. Which is surrounded by fibrosis. Which is encircled by the fibrosis. The most commonest cause for liver cirrhosis in Western population is alcoholic liver disease, and in the Middle East and in the Pakistan, India, and especially among the Muslim patients, the other reason is non-alcoholic fatty liver disease, that is commonly due to diabetic, hypertension and obesity, as well as due to dyslipidemia. Now another cause is, nowadays it is becoming a big problem, chronic viral hepatitis B and C infection. Other causes are literally rare, otherwise hereditary or congenital. So other causes are rare. The most commonest is alcoholism, and if the person is a drinker as well as holding hepatitis infection, his liver will go for fibrosis very fast. Understand? And in the Muslims, it is non-alcoholic fatty liver disease. This is very common. What is the pathogenesis? I told two things are happening: fibrosis, regeneration of nodule. Two things are happening, right? See, even though liver cells regenerate, they are not functionally good. They are not functionally immature. So that's why they cannot bring back the liver function. So there are nodules happening because of regeneration. Why this regeneration happening? From where the regeneration happens? This happens from the pre-existing long-lived hepatocytes. Some hepatocytes are long-living. From that hepatocytes, the liver regenerate. The liver cells regenerate, and another thing is from the stem cells. From the stem cells. So the liver cells regenerate and they produce nodules. They produce nodules. Why there is fibrosis? Because the Kupffer cell is stimulated. The Kupffer cell is stimulated. It will be converted into fibroblast, and the fibroblast, and or they produce uh, growth factors that stimulate the fibroblast to produce more fibroblast and more collagen that leads to cirrhosis. First thing is there is hepatocyte cell death of hepatocytes, and extracellular matrix deposition, that is collagen, that nothing but collagen, and vascular reorganization. These regenerated nodules also receive blood supply, so that's why it is called vascular reorganization. These are the three pathogenesis seen in the cirrhosis. Okay, once the cirrhosis happens, it progressively leads to liver failure, which we discussed, and they produce portal hypertension, and they end up with hepatocellular carcinoma. They will end up with hepatocellular carcinoma. Let us see what is portal hypertension. So portal hypertension is nothing but increase in the portal venous pressure due to cirrhosis, most commonly due to cirrhosis. So another cause is, it is due to occlusion of hepatic vein. That is the another cause which is seen in the hypercoagulable states, tumors and pregnancy. This is called Budd-Chiari syndrome. So you can see the block in the hepatic veins, the thrombotic block in the hepatic veins, that will create portal hypertension. And when there is portal hypertension, the patient will develop ascites. Ascites means accumulation of fluid in the peritoneal cavity. Clinically, you can detect ascites if it is more than 500 ml. If it is more than 500 ml of fluid, then you can clinically detect the ascites. So ascitic fluid will have more albumin. And if you see the serum albumin and ascitic fluid albumin ratio, it should be more than 1.1 gram per deciliter. 1.1 gram per deciliter. How we measure it? Just we put a tap and we take the fluid out and we measure in the lab. Okay, so it is called peritoneal tapping. So we take the fluid out and we measure it. When we take the fluid out, we also see in the microscope. If it has RBCs, if it has red blood cells, if it has blood, we will be thinking of intra-abdominal cancer. If it has neutrophil, we will be thinking of infection. And if there is long-standing ascites, the ascitic fluid can enter the pleura. That will produce hydrothorax. Especially they produce hydrothorax in the right side. Okay, so this is all about ascites. This fluid is coming because of portal hypertension. Now coming to the drug-induced hepatitis. This is nowadays very common, Yani. So it is called drug-induced hepatitis. Very common drugs are causing this problem nowadays, because now we use lot of drugs, and now even the common man is using drugs without asking the doctor. So that is a problem. So most drug reactions are unpredictable. We don't know which drug causes the hepatic injury, and it depends upon what is the agent, what type of drug, and the dose. Okay, and the lesion also varies from one person to one person. It is not specific, like it will happen this kind of injury. It varies from one person to one person, and they produce liver cirrhosis in the centrilobular region. Liver necrosis in the centrilobular region. So we call centrilobular necrosis most commonly due to ischemia and toxicity. We don't have any specific test to identify which drug is causing this damage. So history taking is very important. Now this is most commonest drug nowadays is producing this injury is acetaminophen. you can see the necrosis in the surrounding the central vein. Surrounding the central vein, it is called centrilobular necrosis, and they produce massive necrosis. The patient has to go for liver transplantation. The patient has to go for liver transplantation. Now, viral induced hepatitis, and I am going to discuss about these three viruses in a simple manner. So hepatitis A, B and C are very commonest viral hepatitis. Very commonest viral hepatitis. Hepatitis A spreads through fecal-oral route. Spreads through fecal-oral route, and they will not produce chronic disease or cancer. They will not produce chronic disease or cancer. Vaccines are available. Just they will produce hepatocyte dysfunction and jaundice. Okay. So whereas hepatitis B and C are very dangerous, they enter through paraentral. Paraentral means through blood and body fluids. And remember, they produce chronic disease, which means cirrhosis of the liver, and they will develop into hepatocellular carcinoma. They will develop into hepatocellular carcinoma. And hepatitis B vaccines are available, and hepatitis C we have very good treatment nowadays. Very costly it is. Okay. So we give lot of interferons and some specific hepatitis C viral drug. It is very costly. It is available now. Okay, but the vaccine is not available. Hepatitis B vaccine is available. That's why we tell all the medical students to put this vaccine. Okay, so remember, hepatitis A will not cause chronic illness. They will not produce liver cirrhosis, and they will not produce cancer, hepatocellular carcinoma. Hepatitis B and C, they will end up with hepatocellular carcinoma. Among all, hepatitis C is highly dangerous. They will produce very soon hepatocellular carcinoma. Now coming to the alcoholic liver disease, and see this I want to emphasize here, there is no safe upper limit. Okay, so even small amount of drinking alcohol will damage the liver. Okay, what kind of damage they do? The reason is they produce alcohol is converted into aldehyde. That aldehyde will damage the liver cells. Alcohol itself can directly damage the liver cells, and they also increase the reactive oxygen species, and they induce inflammation. When they induce inflammation, it is called alcoholic steatohepatitis. It is called alcoholic steatohepatitis. So this is the pigment they form, pink color pigment in the liver cell. Okay, it is Mallory hyaline granules they call. Okay, Mallory hyaline pigment. So it's not much important, it's only morphological importance. What you should understand is they slowly start with fatty change, then they become inflammation, hepatitis, then they develop into hepatocellular carcinoma, cirrhosis, then they develop into hepatocellular carcinoma. So 4 stages: fatty change, hepatitis, cirrhosis, hepatocellular carcinoma. So the patient, if they stop drinking alcohol at the fatty change, it is reversible. It is reversible. Now coming to the non-alcohol fatty liver disease, the most commonest cause is type 2 diabetes and central obesity, dyslipidemia and hypertension. These are the major cause for non-alcoholic fatty liver disease. The same process starts with fatty change, then goes to hepatitis, then goes to cirrhosis. Okay, then they can develop into hepatocellular carcinoma. But most of the times non-alcohol fatty disease, they stop by cirrhosis. They stop by cirrhosis. They rarely convert into carcinoma. Now coming to the benign tumors, and the most common benign tumors only I am mentioning here. In that most commonest benign tumor, the hepatic adenoma and hepatic nodule are important. Hepatic nodule is not a tumor, but it confuses with hepatic adenoma. It confuses with hepatic adenoma. So the hepatic nodule are the nodules formed during cirrhosis. Nodule formed during cirrhosis. That nodule will always confuse us with the hepatic adenoma. That always confuses with the hepatic adenoma. So hepatic nodules are regenerative nodules. They are regenerative nodules. They always produce confusion with the diagnostic confusion with the hepatic adenoma. And the most commonest vascular tumor which seen in the liver is called cavernous hemangioma. Cavernous hemangioma, they produce huge blood vessel which contains lot of blood. Okay, dilated blood vessels which contains lot of blood. Now coming to the most important tumor, malignant tumors of liver. 2 tumors, one is hepatocellular carcinoma and metastatic carcinoma. I am going to discuss in detail. And hepatoblastoma is usually seen in the children. Hepatoblastoma is usually seen in the children. And hepatocellular carcinoma, and you know it is comes on the background of hepatitis, usually viral hepatitis, and in alcoholic hepatitis. And it will be a single tumor which expands and compress the normal tissue. Let me explain here. This is a single tumor expanding, and you can see the normal liver is compressed here. So it is like a expansile mass. Whereas in metastatic carcinoma, usually it will be multiple deposits. You can see multiple deposits, multiple nodules in the liver. So when you see multiple nodules in the liver, especially in the elderly people or late adult people, we will be thinking of metastatic tumor. We will be thinking of metastatic carcinoma. So the metastatic carcinoma can come from the gastrointestinal tract, breast, lung, pancreas, melanoma, and hematological malignancies. The most commonly it comes from the gastrointestinal tract and the breast. So it is the tumor coming from the breast or gastrointestinal tract, the cancerous tumor coming to the liver, and they produce multiple deposits. So hepatocellular carcinoma, usually it will be a single tumor, expansile mass, which compress the normal liver. So this is the most important thing. So the normal liver can produce do some functions. Okay, so but the hepatocyte function will be completely affected if the tumor is big. Understand? So the complete liver is replaced by the tumor. Then the liver function will be affected. Okay, so this ends the pathology of liver. Okay, you can go to the Robbins book 603 to 639. They discuss a lot about pathology of liver, and you can read from that resource.